Welcome, everybody, to tonight's program, the perioperative therapy in early stage non-small cell lung cancer, the implications for molecular testing. As most of you know, there's a plethora of information that continues to come out around the various regimens that are being used in the adjuvant and neoadjuvant setting. Tonight, our speaker, Sharu Agarwal, the Leslie Heisler Professor of Lung Cancer Medicine from Penn, is going to help us make sense of all this. So with that, Sharu, I'll turn it over to you.
All right, sounds good. Thank you so much, Charles, and thank you for joining us. I think this is a very exciting time in lung cancer. I have a few slides, and then we have a few cases that we can go through. I think it would behoove us to just talk about lung cancer for non-small cell lung cancer. Back in 2002, on the left, you can see our median overall survival only used to be 8 months. But with the introduction of targeted therapy, such as alectinib that you can see in the middle, as well as immunotherapy, 5-year survival rates have significantly improved. Now about a third of the patients are alive, even when they walk into the door with a diagnosis of stage 4 non-small cell lung cancer. So based on this, there has been a lot of interest in application of either targeted therapy or immunotherapy in the management of patients with early stage lung cancer. And today we'll talk about a few studies, and this has actually come about within the last 2 years. We've had so many advances in approvals. As many of you know, adjuvant therapy for EGFR mutant lung cancer was studied in a trial called ADAURA. We'll talk about that. We'll also talk about adjuvant immunotherapy following surgical resection. There are now 2 big studies that have read out and have been reported, both with FDA approvals. One is the Empower 010, and the other one is Keynote 091. We also have neoadjuvant chemoimmunotherapy. This also led to an FDA approval, the Checkmate 816 regimen. And then most recently presented at AACR just last month in April, the use of both, which is neoadjuvant and adjuvant immunotherapy with durvalumab, the trial called Adjuvant. So without further ado, we'll begin off by saying that what is the role for adjuvant therapy? Historically, we've used chemotherapy in patients with non-small cell lung cancer. But as you can see from the disease-free survival and the overall survival hazard ratios, the benefit is minimal, with a hazard ratio of 0.84 and a hazard ratio of 0.9. Maybe leads to a 4 to 5% improvement. But, I think there's room for a lot of improvement based on the new agents. A lot of factors go into making a decision process or making a decision based on drug, mechanism of action, what's the safety, potential for harm, magnitude of clinical benefit, cost, etc. ADAURA was one of the first trials to evaluate targeted therapy in the adjuvant space. And this was reported now about 3 years ago at ASCO 2020. This was a phase 3 double-blind study design where patients underwent resection and then went on to receive either osimertinib once a day or placebo. Couple of things to remember for this trial. They included stage 1B and higher. So stage 1A patients were not included. And then EGFR mutant patients that were included were exon 19 deletion as well as L858R. So none of the exon 20s, exon 18s were not included. And as you can see on the right, significant improvement in disease-free survival for patients with stage 2 and stage 3A with a hazard ratio here, which was significant, 0.17. And recently, we heard a press release that there is an improvement in overall survival as well. And actually, at this year's ASCO annual meeting, the ASCO abstract titles were just announced, and this is going to be a plenary where we're going to see the overall survival results from ADAURA. So this is now approved, available. Even though we haven't seen the results, the press release tells us that there is an overall survival advantage. What about the adjuvant use of immunotherapy? So the first trial was Empower 010. This evaluated the use of atezolizumab. Again, the same population, 1B to 3A. Slight difference here. This trial mandated the use of chemotherapy. So 4 cycles of chemotherapy had to be employed before patients were randomized in a 1:1 fashion to receive either atezolizumab for a whole year or best supportive care. The statistics were interesting. They were tested in a hierarchical fashion. First, DFS was tested in the PD-L1 positive stage 2 to 3A population. This is important because this is tied to the FDA approval. And this is what we found in the initial reveal of the results. So the FDA approved indication is on the far left. You can see that DFS in this patient population was improved with a median follow-up of close to 3 years. DFS improvement was 0.66 hazard ratio. Lower level of improvement in all randomized patients, and in the intent to treat population, which included 1Bs, it wasn't really that significant. There is there are hints that the higher the PD-L1, the better the efficacy. You can see PD-L1 greater than or equal to 50% hazard ratio of 0.43. And if you have an EGFR or ALK mutation, probably not the best treatment to go on. As you can see, these are the subgroups excluding EGFR and ALK, and above you can see the subgroups including EGFR and ALK, and overall hazard ratio is closer to 1, that is if you exclude them. Interim overall survival results do look positive. Here you can see hazard ratio is 0.71. Again, this is for the entire population. This is much better for patients with PD-L1 greater than 50%. This is also approved, again, for this indication, PD-L1, TC1 or greater, stage 2 to 3A. This was the first indication in the adjuvant space. Again, I think if we have somebody with an EGFR mutation or ALK, probably not the best candidate to get immunotherapy. But then we have, you know, when you have diet, you have Coke, you have Pepsi. When you have Uber, you have Lyft. So when you have atezolizumab in the adjuvant space, you're going to end up having pembrolizumab or another agent being tested. And this is the PEARLS trial, which was also a global randomized phase 3 trial, looked at the exact same population, 1B to 3A, complete surgical resection. The only difference is they did not mandate chemotherapy. Patients were eligible for randomization irrespective of having received chemotherapy, and they went on to receive pembrolizumab or placebo. And overall, you can see that the patient populations were quite well balanced. I mean, I placed them here not to increase complexity, but to generally give you an idea that all of these numbers look the same. For example, patients with stage 3A were about a third of the population. Very few EGFR and ALK mutant patients, but for example, current or former smokers were about 90%. So the populations were generally well balanced. And what we found was that 2 things. First, overall DFS, irrespective of PD-L1, was positive with a hazard ratio of 0.76. You can see on the left, green is pembrolizumab. And then on the right, you can see for patients that had PD-L1 greater than 50%, and this was really surprising data, that for patients greater than 50%, hazard ratio was actually worse than it was for the PD-L1 negative or 1 to 49%. So this is not very clear. And in fact, if we were to compare it to Empower, the Empower 10 DFS hazard ratio for all comers was about 0.43. So we know that immunotherapy works better in PD-L1 greater than 50%, but why this is occurring is not clear, either the assay or the tumor heterogeneity, or maybe, some speculation is that the control arm actually overperformed for these patients because as you can see, the median DFS here is actually quite good. So could it be that the control arm actually did much better, are some of the reasons. But also it's interesting when we look at some of the subgroup analyses. Patients who didn't receive adjuvant chemotherapy, placebo was better, but patients who received adjuvant chemotherapy, pembrolizumab was better. And then there are some differences in terms of which chemotherapy was used. So surprisingly, if somebody receives carboplatin plus vinorelbine, they did better. And then the PD-L1 subgroups is something that we really can't, sorry, I'm going the wrong way, are something that we really can't explain here. You can see, the PD-L1 greater than 50% being the closest to 1, as well as the patients with stage 3A disease being closer to 0.1 at 0.92. When we know that the highest risk patients, those with the highest nodal disease, as well as high PD-L1 will benefit. So the results of this trial are a little murky. However, irrespective of this, the FDA did grant its approval. And there are a couple of differences in the approval for Pembro and Atezo in the adjuvant setting, that Pembro does not have a stage-specific approval. It also doesn't have a PD-L1 specific approval. So it's basically for all comers. If you wanted to use it, you could use it. But now we have another option. We talked about it. We have Checkmate 816. And this is the trial design. This is basically neoadjuvant use of 3 cycles of chemoimmunotherapy, exact same population, right? So we're talking about 1Bs to 3As. They excluded patients with EGFR and ALK. So I think important to test. We'll talk about this a little bit. And then gave them 3 cycles of Nivo plus chemo versus chemo alone. They looked at surgical rates and PAT-CR rates, as well as event-free survival. Patients who underwent chemo-IO had significant improvement in event-free survival with a hazard ratio of 0.63. As you can see, the curves are staying pretty parallel even at the 42-month mark. And you can see that the patients on the right that are the higher stage N2 disease, stage 3As, tend to have a much greater benefit. The hazard ratio or the separation of the curves is much better at 0.54. Stage 1Bs to 2, maybe not that much. And then again, as we would expect, PD-L1 greater than equal to 50%, significant improvement. The curves are really far apart. Hazard ratio is only 0.24. But it's important to also point out that all PD-L1 levels did benefit, hazard ratio of 0.58 here. And then overall survival for patients who do receive it seem to have an improvement in overall survival. And I think this is one of the key takeaways from this, is that patients who receive a limited duration of immunotherapy in the neoadjuvant space tend to do better in terms of survival. So this trial, Checkmate 816, did not employ adjuvant immunotherapy. So it basically stopped at 3 cycles of chemoimmunotherapy given perioperatively. But now we have Adjuvant, which is building upon and sort of trying to be a disruptor in this space, and telling physicians that you should do basically you should do 3 or 4 cycles of neoadjuvant chemoimmunotherapy, and then you should also add on 1 year of immunotherapy. So this was a randomized phase 3 trial. Again, if you look at the patient population, slightly different, 2A to 3A here. Patients did have to have surgical resection. Again, no EGFR or ALK, randomized to 4 cycles of chemoimmunotherapy or chemotherapy. They all had surgery, and then patients went on to receive durvalumab. They looked at PAT-CR as well as EFS. And here you can see EFS is better with Aegean. So in the Durva arm, you can see median EFS not reached. Placebo is 25.9 and a stratified hazard ratio of 0.68, very similar to what you can expect with Checkmate 816. The p-value is very significant. Median follow-up is short. If you remember, for Checkmate 816, we had a slightly longer follow-up, slightly over 2 years. It's short of a year follow-up. EFS maturity is only a third. So this is a very early look at the data. And overall, I think if we look at the forest plot, basically all patients seem to benefit, although there are some confidence intervals that do cross 1. Some of which are interesting are the never smokers don't seem to benefit as much. You can also see here the PD-L1 greater than 50%. Again, this is surprising. Again, this is a TC cutoff. we don't really know if the same PD-L1 cutoffs apply to durva. So I think that's a thing to speculate about. And then females didn't benefit as much, and it's not clear why that happened. So if we look at path responses per ISLAC methodology, PathCR by central lab, about 17%. It's been a little higher on Checkmate 816. It was about 24% on Checkmate, and it's about 17% here. And then the major pathological response rate, which is less than 10% of viable tumor, is about 33%. But MPR rate is not really regarded as a surrogate of overall survival, at least not in breast cancer. PathCR is, and I think there is move towards adopting PathCR as a surrogate marker for survival, even in lung cancer. So given all of this data, there's adjuvant targeted therapy, there's adjuvant immunotherapy, there's neoadjuvant chemoimmunotherapy, and then there's both. It's really important to test. So molecular testing is usually done by medical oncologists because we see all the stage 4 patients, and we do usually take ownership of it, but that's not usually the case for early stage patients. And there's also a 14-day rule, at least regarding surgically resected samples. So it's really important that we think about reflex pathways and coordinating care with pathologists as well as surgeons and interventional pathologists. This is something that we wrote a few years ago, but I think very relevant now in terms of how we can think about molecular testing. So if you have a patient with clinical stage 1 to 3 non-squamous non-small cell lung cancer, if they have a biopsy at my institution, all of them are getting reflex testing, which is ordered by the pathologist and is sent to the molecular lab, and we do all of the gene testing. We do the full panel. If they don't have a biopsy and if the tumor is resected, then we send it reflexively on the tumor sample. And then we, of course, think about rebiopsy, or if the tumor is resected, if there is no reflex pathway in place, we think about ordering it or alternative resection samples. So with that, I can stop there and go to cases, but curious if there are questions before we move on. I realize in the past 20 minutes, I've given you a lot of data, but happy to discuss.
Can you, we have 2 different adjuvant regimens with immunotherapy. I'm not talking neoadjuvant, I'm talking adjuvant. What is your preference? Would you use atezo or would you use pembro?
Yeah, it's a great question. And I was going to poll the audience and see what you all are doing as well. I will say that atezolizumab was approved first. The data looked much more consistent with what we would expect in the metastatic setting. I tend to use atezolizumab. I actually hesitate to use adjuvant immunotherapy in patients with PD-L1 negative disease at this point in time, especially those with smaller tumors or node negative disease. So in summary, my preference has been to use atezolizumab. What are you doing? It's a very confusing landscape. I showed you some of the inconsistencies with Keynote 91. Are you using pembro?
Yeah, we use a lot of pembro in our practice. Atezo is not necessarily the preferred, IO. I guess maybe it's just that we use pembro across multiple cancer types. Maybe that's probably another reason why we use a lot of pembro. I just want to follow up one other question. This has been something that I constantly am, struggling with. Are you all seeing a lot of patients with early stage lung cancer with lung cancer screening?
It's a very good question. We just looked at our data, and actually 80% of our surgical resections, or maybe 70% of our surgical resections, were for stage 1A or stage 1A1 or stage 1A2 lung cancer in the last 2 years. So, these small tumors are forming the bulk of our surgical resections, and it it likely has increased somewhat over the last 5 years. And it was very surprising to me that we are doing so many of these resections. So I would think that, yes, probably the numbers are going up, especially for these early stage, very early stage lung cancers. Has that been your sense as well? Are you seeing more referrals for stage 1?
No, in fact, that's something that I would love to see implemented, but it's very difficult to put together a program, because there's a lot of different specialties involved. You're looking at also making sure that the radiologists get reimbursed. I understand that it's the CMS actually has approved it, and so has some of the insurance carriers, but that has been one of the limitations. There is also lack of, I have to say, I wouldn't say knowledge. I guess maybe the primary care physicians don't have time to even screen patient or rather ask questions about smoking history. This is very much unlike breast cancer and prostate cancer. So thank you.
Approach PD-L1 negative patients any differently?
In the adjuvant setting or before they get surgery?
I suppose just both.
Yeah, so I think, if they have a small tumor, if they're stage 2, and 1, not a smoker, no molecular mutations, I would probably not give them adjuvant immunotherapy because I think the benefit is minimal. Especially if we look at the overall intent to treat population for Empower 010, I mean, it didn't even meet the criteria for significance. And then the Keynote 091 is really all over the place. It seems to be more beneficial for PD-L1 negatives, but also less beneficial for stage 3As. So I don't know if I believe that data, and therefore I would probably hesitate to give them immunotherapy for somebody that has a lower risk tumor. I think if a patient has a stage 3A PD-L1 negative tumor, on the other hand, in a tumor board, we are probably more likely to push for neoadjuvant chemo IO, just because I don't think that the benefit of adjuvant immunotherapy is really all that great. So I think if in that kind of a patient, if we are able to get a path CR, we really have the ability to improve survival by administering this short course of chemo IO. So that's how we are thinking about these patients. Of course, if somebody has PD-L1 greater than 50%, I think either approach is reasonable, right? To do either neoadjuvant or adjuvant, because they're going to benefit no matter what. But I think this is sort of our strategy for PD-L1 negatives. I hope that's helpful. How are you thinking about this? Are you using immunotherapy in your PD-L1 negatives in the adjuvant space?
No, and it's not on our pathways. So it's really not an option. And I was kind of thinking, honestly, everything that you've said is kind of conforms with our pathways, the way you think about it. But yeah, it's simply just not even an option for us.
Are you testing everyone up front, or are you doing testing on surgical resection samples?
Both. Yeah, sometimes it's a little tough to test on the biopsy, and then I'll try to get a liquid NGS on them, but certainly on their surgical resection.
Sounds great.
I have a quick question, actually.
Yeah.
Just on this topic. So 2 kind of scenarios that I'm kind of curious to get your thoughts on would be people with early stage lung cancers that received radiation and not surgery, and the role of immunotherapy in that setting. And then kind of my second question would be like a high risk patient, like a non-small cell lung cancer with high grade neuroendocrine features that were PD-L1 negative, and maybe a role of immunotherapy in that setting. Sorry for the very specific questions, but just curious on your thoughts.
Yeah, these are the kinds of questions that are brought to tumor board. We have considered using immunotherapy in patients who are like, sort of a medically inoperable stage 2, or let's say a tumor size of 4 centimeters, node negative, but they're sort of like medically inoperable. And what do you do? If they have a high PD-L1 expression, we have in the past considered using adjuvant immunotherapy, sort of trying to give them the best treatment that we have. But oftentimes we find that patients who are medically inoperable or surgically unresectable are also not able to receive systemic treatment. I don't know if that's your experience as well. I mean, we're selecting out cases who are unable to get these surgical resections. So they often have, poor performance status, or they're wheelchair bound, or they have horrible COPD, or their pulmonary function is in the toilet. So we usually just do this discussion on a case-by-case basis, and I don't think there's any right answer. As you know, there's no data to support it. There are some upcoming clinical trials, such as Specific 4, that are evaluating the use of consolidation immunotherapy following SBRT. So I think for early stage lung cancer. So I think once those kinds of trials read out, we'll have more of more answers. But at this time, I think it's a case-by-case basis. And then the high-grade neuroendocrine differentiation question is a very good point. I think we would consider a neoadjuvant chemoimmunotherapy. If they're truly not small cell, and they're stage 3A high grade, we would probably consider a neoadjuvant chemo IO with a taxane as the platinum partner. But would just really stress the pathologist to give us whether this is neuroendocrine or is this truly small cell, so that we can make a decision, because we don't want to obviously resect a small cell. Have you thought about employing the Adjuvant trial into your practice? Or I guess another way to ask this question is, when you've used neoadjuvant chemoimmunotherapy and you haven't achieved PAT-CR, have you done 1 additional year of immunotherapy?
I haven't used a lot of neoadjuvant, just from my experience. I mean, I don't know why. I just haven't had the scenario. Just been a lot of adjuvant or, chemo RT. I don't know. I haven't done it a lot.
Yeah, neither have we. We are not a very big neoadjuvant place, but I think based on all of this collective data that's coming up, we have to get together and really, sort of revamp our thinking and think about, especially for patients with PD-L1 negative disease, really think about coming in with neoadjuvant treatment.
So this is a 62-year-old female who presented to the ED due to pelvic pain. She got a CT abdomen pelvis, which caught something at the bottom part of her left lower lobe. That led to further imaging. PET-CT revealed 3.3 centimeter mass, left lower lobe, and then adjacent small little nodule, too small to characterize. She has a long history of smoking, quit recently, 20-pound weight loss. She underwent a biopsy, revealed poorly differentiated squamous cell carcinoma of the lung. This is one where the sample was not good enough to get a conclusive result on the biopsy NGS. But on liquid NGS, she did not have an EGFR ALK mutation. Underwent carbotaxol Nivo per checkmate 816. And left lower lobe lobectomy revealed 0.8 centimeter, 5% viable tumor noted. Now, so just kind of following the protocol, I'm giving her adjuvant carbotaxol. But it kind of begs the question that you just mentioned, is that given that there was some residual tumor, would she benefit from additional immunotherapy?
You didn't tell us the magic key point. What was her PD-L1?
Oh, I didn't. That's right. So, so yeah, her PD-L1 was, it came back at about 10%.
Yeah, well, We'll say 10%, right? Because it's sort of like in between the 1 to 49%. Even if you didn't have that, that's a nice number to sort of assume for a case like this. It's hard, right? This patient has had major pathologic response, but not PAT-CR. We know that her outcomes are going to be in between those with a PAT-CR versus those who don't have a PAT-CR. On Checkmate 816, they did not administer additional nivolumab. So I would say that she has better than no response. And I would just say, just watch her and not do any further immunotherapy, especially with a PD-L1 of 10%. I wonder what everyone else would do. I think, again, completely data-free zone. A lot of intergroup trials are being at least imagined at this point in time for these patients who don't have a PAT-CR. Like, what do you do? Curious what other people would do.
I would give Nivo. I would just, I hate to, kind of violate the rules, but just like the Durva study, I would probably give the Nivo. I mean, this patient has a very high risk for recurrence. She has poorly differentiated squamous cell. These are bad actors. We know this is going to recur at some point. So at least that's what I would do.
Yeah, and I don't
And
think
she's
that's the wrong
62.
answer. Yeah, because I think you could totally defend that by saying that Aegean gave 1 year of Durva, and their major pathological response was higher, and the patients who received it had better outcomes. So I think you could totally defend that decision. It's just going to be so hard to talk to patients as well and say, do we give it, do you not give it? I think these conversations are going to continue to become challenging.
I mean, if it's approved, I think it's an easy drug to give, and it's very well tolerated. So and she's young, she's 62. So.
Actually
So
had a
if it's
very similar case. And patient actually was asking to get additional immunotherapy. He did really well with neoadjuvant immunotherapy. And I think the PD-L1 was even lower. I think it was like 5%. And we also had the discussion about just omitting it, giving the low percentage major response. But the patient was just asking for it because he did so well with it. And he's currently still on it, doing well. So it's always a discussion with the patients.
Exactly. Yeah, exactly right.
So if the Aegean was approved and this patient presented 2 months from now, would that be your preferred regimen?
So, I think if this was, you didn't tell us whether or not this patient had nodal involvement. Sounds like this patient only had, left lower lobe mass. So probably like a stage 1C or 1B. Yeah. So stage 1B, we would probably take directly to surgery and not really do neoadjuvant. But we would make every attempt, as I'm sure you did, to make sure that their nodal sampling was performed, EBUS was performed, and all of those things. I think we would start thinking about an Aegean kind of an approach in a stage 2 or higher. Remembering that Aegean was stage 2 and 3A by AJCC 8th edition, so as well. So this patient technically without any nodal involvement would not be an Aegean candidate. And we don't know how the FDA approval is going to read out. So it may just be perioperative or it may be stage specific. We don't know yet. All right, I'm going to move on to the next case. Dr. Reddy.
Okay, so this is a recent case, elderly female, close to 79-year-old female with very distant smoking. She told me 30, 40 years ago, minimal smoking back then. She was having some non-specific findings. To make long story short, she had an incidental lung nodule. She also has somewhat compromised cardiac function, but in any case, she underwent a wedge resection. Pathology was poorly differentiated adenocarcinoma, 3.2 centimeters. Patient actually saw me about 6 weeks after surgery. So when I reviewed the pathology report, it was she had a positive vascular invasion and poorly differentiated cancer. The staging was 1B. I did not have the NGS results at that point, so then I ordered. So while we are talking for that, I recommended chemotherapy. Now, one of the questions I have is that when I looked at the NCCN, it says, chemotherapy obviously because of the two high risk features. I was thinking of carbolinta. They did not show any interest, but I think 2-3 weeks later, the exon 19 deletion came back. So at that time, I offered osimertinib. It's so far doing well. The question was, I think in NCCN back then, I was just pulled right now also, it said for high-risk patients, chemotherapy followed by osimertinib. I was wondering if that's the way you practice, or if this patient was seen like within 3 weeks, would you go straight for osimertinib?
Yeah, such an interesting case. And thank you for highlighting these, because I think this is important. So on the ADAURA trial, the population that benefited the most were the stage 2 to 3As, the curves that I showed you. The disease-free survival hazard ratio was 0.17. For those patients with stage 1B were included, but didn't seem to benefit as much as those patients with stage 2 to 3A. So the indication, if you look at the FDA approval actually is stage agnostic. It just basically says surgically resected non-small cell lung cancers with an EGFR mutation. So you're absolutely right to be able to give this patient osimertinib, but maybe the benefit will not be as high as it will be for a stage 3A. The second question about chemotherapy, not every patient on the trial actually received chemotherapy. They did subset analyses on both arms, both the osimertinib arm as well as the placebo arm. About 2/3 of the patients received chemotherapy and then went on to receive osimertinib, and about 1/3 did not. And when they did the subgroup analyses, they saw a benefit for osimertinib, regardless of whether or not adjuvant chemotherapy was administered. In my practice, before the overall survival data came out for ADAURA, in my practice, I always used to give adjuvant chemotherapy, and I think we'll continue to give adjuvant chemotherapy based on an improvement in overall survival, and I will follow it with osimertinib. I think for somebody like this with a 1B, I think you could go either way, because for a 79-year-old, the data to use a carboplatin-based chemotherapy regimen is just not that great. So I think being practical for a 79-year-old with a stage 1B who has positive vascular invasion, I would have exactly done the same thing. I would have probably skipped chemo and gone with osimertinib, even though the benefit is small.
But the NCCN guidelines, somehow I was a little worried about it. If I give osimertinib without chemo, I may not be justifiable. So I wanted to give like maybe one cycle. But that's how the NCCN guidelines, even for 1B, it says chemotherapy followed by osimertinib.
Even for 1B, even for
yes.
a 3.2 centimeter?
1B, yep, yeah. I just pulled that again. I remember back then why I was offering 80-year-old chemo just to justify myself. But even now we are pulling for 1B chemotherapy for high-risk patients followed by osimertinib.
Yeah,
that's how I'm saying.
I think you did the right thing. Just giving her chemotherapy would not be easy.
Okay,
yeah.
Thanks.
Yeah, interesting. And I think just highlights so many things about osimertinib here, about the stage as well as the use of adjuvant chemotherapy.
So you mentioned about carbo. So for these patients, if this patient were to be 59, would you give cis?
With the stage 1B, I would have a discussion. I mean, I think
if it's high, I mean, she's high risk. I mean, she has vascular invasion. She's
I would probably, if I have to give it and she's 59, I would probably use cisplatin. Yes. Hard, I know, but I mean, a 59-year-old would probably be able to tolerate it. Yeah.
It's a quiet group tonight.
It is.
It's late.
We also share a lot of data. So, I mean, it's just exploding in the lung cancer space. Actually, at ASCO, there are going to be 2 more perioperative trials that are going to be reported. One with Pembro, actually, Keynote 671, which is using both neoadjuvant chemo IO followed by a year of Pembro. So we'll see what happens with that.
What do you think you'll be doing at Penn when Adjuvant gets approved? In other words, will it replace 816? How will you work that in?
It's a tough question. I think we'll probably do a GN kind of a regimen, just as we discussed with the last case. You know, somebody's young and they've had like a major pathologic response, but don't quite have a PAT CR. They tolerated immunotherapy well. We'll probably end up continuing immunotherapy for a year.
Will it be the
That's
Aegean
where we're
regimen,
going
or will
to
you do a modified 816?
What's that?
Will you use Aegean, or will you do a modified 816?
Honestly, I think it's going to be all over the place, Charles. People are going to start off with 816 and then add in their choice of immunotherapy, I think. I think that's practically how it's going to play out. They're going to say, all right, I think I can get a Tezo. I can get Pembro approved, and they'll add that on in the adjuvant setting. I'm curious to see what other people think. That's just my prediction. I see lots of nodding heads, but curious. Do you think you agree? You're muted.
But you know, at least in our practice, I think it has a lot to do with community practice. It has to do with preferable IOs. You know, not all private practices actually resort to giving all IOs out there. There are preferred drugs, and we're going to choose what is preferred. Because when all is said and done, I mean, you know, I don't think there's any difference between any one of these IOs. I'm not talking about CTLA4 inhibitors. I'm really talking about PD-1 and PD-L1s. So I just see that happening. At least I can't see anything different than what, you know, we're going to choose. It's kind of dealer's choice, I guess.
Contracting.
Exactly.
Interesting. Makes sense. Other questions? Well, if not, we'll go ahead and wrap it up. And Shreya, thanks for a great talk and concise summary of the world as it's changing. And I hope everybody has a pleasant evening. Have a good night.
Have a good night. Thank you. Bye.
Thank you. Thanks.
Appreciate it, guys.
Good night.